Let's do pulse. I used to believe that pulse was actually the pressure of the blood that I feel in the peripheral arteries, but it's not the blood, it's actually a pressure distension wave that is produced against the walls of the arteries as a result of the contraction of the left ventricle. The transmission of this pressure wave is because the aorta is already partially filled with blood against which the left ventricle pushes out. Stabilize the artery against the bony prominence, distal finger to prevent the retrograde pulsations from the palmar arch, and the middle finger to count and feel the pulse. Normal pulse waveform of the arterial pulse trace. Solar upstroke is the ejection phase of the left ventricle. The first half is rapid and the second is the slow ejection phase. So it's known as the percussion of the forward wave. This upper part may actually also be the reflected waves from the upper part of the body, which is known as the tidal. And this peak of the wave is your SPP. So it's obvious that this is your systole. Naturally, here your diastole will begin. And this is where you get your second heart sound, which means your semilunar valve closed here. Now understand that because of this closure, there is a little push and then a relaxation. Therefore, we have this notch here, which is called the dicrotic notch. And if this was your SPP, this is where you'll get your diastolic BP. And this normal waveform is called a catacrotic pulse. Catacrotic is Greek for upbeat. Now the stroke volume, ejection velocity, the vascular resistance, and the vascular compliance are going to determine what kind of abnormal pulse you're going to get. Normal pulse for comparison. Now pulse is parvus. Parvus means small. So you basically have a normal waveform with a smaller amplitude. Obviously seen when the stroke volume is reduced, as possible in shock, or in mitral stenosis when the left ventricle does not have enough blood. You can have a pulsus tardus, which means a slow rising pulse, and the ventricle is conducting slowly as a result of some bundle branch block. These things remain normal. Now in pulsus parvus A tardus, you will see both small and slow. Like in a patient of aortic stenosis, you're trying to push out the blood, but because of the stenosis, your ejection velocity is also reduced and your stroke volume is also reduced. So you get small and slow. In severe aortic stenosis, you may also see a pulsus anacroticus, which means there will be a small anacrotic notch before we have the low volume pulse. Notch because difficulty in pushing out blood through the stenosed aortic valve. Another type is a spike and dome appearance, which is seen in HOCM because the hypertrophied intraventricular septum will push into the left ventricle and cause a left ventricular outflow tract obstruction. As a result, the blood flow is going to be difficult. So obviously there is going to be an initial spike, and this dip is because of the difficult pushing out. And then you have the tidal wave because of the peripheral pulsation. My favorite, the water hammer pulse, wherein we have a rapid and large volume upstroke, and also we have a collapsing nature of the downstroke. As you can see, it's hyperdynamic, so you will see it in hyperdynamic conditions like these. And you also see it in aortic regurgitation. See, because of aortic regurgitation, we have increased end diastolic volume in the left ventricle, causing an increase in the stroke volume because the walls have been distended that much. And also during diastole, you're going to have that quick runoff from your peripheral arteries into your left ventricle through that aortic regurgitation. That is why the collapse. Next is bispherians, which means there are two peaks in the systole itself. In severe AR, like we discussed, there was an increase in the stroke volume and ejection velocity. Now, because of the super high ejection velocity, there is going to be a drop in the pressure on the walls of the aorta according to the Bernoulli's theorem. This is that drop in pressure. And that drop actually separates the percussion wave from the tidal wave. Now again in HOCM, because of the LVOT, that obstruction is going to delay the tidal wave also. And AR plus AS. AR ki wajah se we'll have the rapid upstroke, and AS gives us the delayed tidal wave. These two peaks were in the systole itself, but in pulsus dicroticus, we have two peaks, the second one being in diastole. Now, in conditions with an increased peripheral vasoconstriction or basically an increased systemic vascular resistance, there is going to be an increase in the pressure during diastole also. So there won't be a low pressure, there will be a high pressure, thus giving us two upstrokes. Finishing in part